Dear colleagues, dear friends, dear Jill, first of all, many thanks for this very kind invite to be able to provide you and the community some perspectives on topics of interest to all of us. There is a tremendous amount of work that has been done over the past year in pathology, and I have chosen one topic which I think is very relevant to all of us, is how can we have added value for you, for us pathologists, and for our patients in the AI field, in the digital pathology field. And conflicts of interest. The first question, which is on the mind of everybody, is are AI-Assays better than pathologists? There is this general thinking that AI will solve everything, from wars in Ukraine to our daily practice issues with our patients. Is this true? Let's have a look. A study presented last year at the San Antonio Breast Cancer Conference illustrates a major important point. In order to validate AI-Assays, we need clinical trials. So this is already a request to the community. Make your clinical slides from your trials available to the community so that we can develop appropriate analytical clinical validity studies such as this one. This was performed in the APHINITY study. The APHINITY study, you know it better than I do, early stage HER2-positive breast cancer, Pertuzumab and Trastuzumab versus Trastuzumab alone. It was a positive trial with a marginal benefit in survival. So what we did in this study, we analyzed the Immuno-Infiltrate manually, the pathologist using a microscope, me, a computerized method without AI, so a digital method able to score every single lymphocyte on the H&E slide. And the third one is a digital method automated with AI. And which one of those three performs better? The first observation was looking at concordance between a variety of pathologists to score a large set of slides. It was excellent in terms of concordance. So in terms of analytical validity, we may say scoring manually is good enough. But is this also clinically relevant that we are concordant? We analyzed and we compared manual, so just a pathologist using his eyes, with digital methods, AI-based and non-AI-based. And what we see is that the concordance in general is actually not so good. And this is important because we then tend to think, no, this course on some of those two is wrong. And if you look at a certain cutoff, which in order to compare these essays, we looked at the 75 percentile, which approximately corresponds to 50 to 60% of TILs. A concordance is around 80%, but it's not 100%. So there is a margin of difference between these different methods in finding the same set of patients, namely those with high TILs. How can we use this information in terms of they are discordant to some degree, and is this clinically relevant? And does this discordance matter? And how can we solve it? The first observation is whatever way you look at the Immuno-Infiltrate, it is prognostic in this very large prospective retrospective analysis of a very large amount of HER2-positive patients, nearly 5,000, very long follow-up, 8 years follow-up. So if you look at manually or digital AI or digital non-AI, the outcome is excellent. Irrespective of the method, the more you have, the better the outcome, irrespective of how you look at it. Second, if we start to combine manual, so me looking through a microscope, you see the microscope here, with an AI metric, it enforces the prognostic ability to discriminate patients between high and lower outcome. Here you see, for example, in the Pertuzumab arm, and that's important because remember, all the patients got Herceptin. This is plus Pertuzumab. If you combine both of them, the manual method with a specific metric using AI, you can find patients who have 97.2% invasive disease-free survival. And please correspond this to the outcome which you see in the non-biomarker selected population. And it is, don't tell it to nobody, 92%. So you can easily find patients and discriminate patients who will do excellent when you give Pertuzumab with a high infiltrate when you use both manual and AI. Okay. And when we look at prediction to the response, we see pretty much the same. Manual, AI, digital, and digital non-AI all predict benefit. But also here, if you combine a manual method with an AI method, you can find even more patients that have benefit to the combined treatment. But importantly, the immune-infiltrate aspect of prediction is different than the one for prognosis. So the immune-infiltrate, its prognostic or predictability is different depending on where the immune cells are. This is something that pathologists are not able to discriminate. We can only tell you how much they are, but we cannot quantify where they are. That's why we need AI. And this is an AI-Assay developed by a startup called Case 45. It's a partnership. And this combination with AI tells spatial patterns with manual methods is very powerful to give you information which both of them independently can't. So the conclusion is, irrespective of how you use this method, meaning scoring immune infiltrate, irrespective of the method, all of them find nearly the same thing, despite not being concordant. Remember in the early days, in the early slides? But when combined, you can enhance the prognostic and predictive capability of each method. So that's an important notion already. So manual is not worse than automated, or vice versa. Combined is the way to go. A second question, what defines a good assay in artificial intelligence? We don't know. Is it concordance? But we have seen in the previous presentation that the concordance can be very bad and yet still have prognosis and predictive ability. So is it an outcome, or is it concordance, or a combination? So this study presented by Julia, brilliant oncologist from the Peter Mac, she analyzed in a large set of 7 phase 3 trials in triple negative in the adjuvant setting, 7. Illustrating again the notion that we need clinical trials to develop and validate AI-Assays. So once again, to all of you looking, make your slides available. We can help. We have plenty of experience to develop models to make these slides available so that we can learn increasingly and exponentially on AI-Assays. We compared a variety of different AI metrics, all of them scoring the same thing, namely TILs. But as in a previous presentation, scoring TILs in different segments of the cancer. And we looked at, does it matter in terms of outcome? Also here, we saw that the correlation between the manual assessment using the microscope and the pathologist using the microscope, and the AI-derived metrics is actually moderate, not excellent. And all of them were prognostic. The more, the better in outcome. Just as the previous one. Moderate concordance, yet both of them combined. Not yet both of them are predictive for outcome. And then we start to combine and look at different combinations. And the important concept for daily practices is if a pathologist looks at the microscope and defines manual tests, this is already prognostic. And if you would do on top of that a computational TIL assessment in triple negative, it doesn't add that much. But the nuance here is if you would start with a computerized TIL assessment, that's also good. See, because it also predicts outcome. But in daily practice, since scoring TILs just takes a few minutes, many pathology labs increasingly globally in different continents score TILs starting with an HED. But in the future, it is invisible that some labs will start to do AI immediately. So the main conclusion from this study, manual assessment is good. And it is not improved if you add a computerized method on top of it. But the nuance is you can also use a computerized method to score TILs because it's also prognostic. And the third element, and this is clinically, I think, personally most important to you, certainly oncologists treating luminal breast cancer. How can the immune system inform luminal disease? So in this study, in the TAILORx, which is the TAILORx study, which we all know because it has formed the basis of recurrence score in our daily practice. So in that study with 15 years follow-up, we looked at two things, the outcomes of ductal versus lobular, and whether the immune system can help us define patients who recur having low risk. So the first observation is that the longer you wait, we start to see a decrease in survival of a patient with invasive lobular cancer, which enforces the notion that it's crucial to make a good diagnosis by the pathologist. Up to 5% difference at 15 years follow-up in overall survival for our patients with invasive lobular cancer. 5% overall survival worse than ductal. That's clinically relevant, I believe, as a pathologist, because the TAILORx was a clinically low-risk population. And then we looked at the Immuno-Infiltrate, and not just looking manually, because we looked at manually on the TILs, and it wasn't prognostic. But then we started to use an AI method to start to find patterns. And together with this partner, PS45, we developed a metric called TMA risk score, which combines every single pattern of immune infiltrate that we can see on an H&E slide and combine it with a metric of the tumor microenvironment, namely the fibroblast and the interaction of immune cells with the fibroblast. We put all of them in one score, in one number. And what did we see? That in patients who are low genomic risk, less than 25 recurrence score, there is a population that has high clinical risk. So those patients nowadays get the advice, we will not give you chemo, madam, or we will not give you more than 5 years endocrine treatment. But these patients are clinically high risk. And these are the patients in our daily practice that recur while having a genomic low risk. And I'm confident this is the same for MammaPrint. This is the same for breast cancer and next, and this is the same for Prosigna, because all those gene expression profiles measure cancer cells, and they ignore the immune system. So every single JEP in the future needs to do both. And the evidence is accumulating, as you will see in 2026, which I will summarize for Gilles and all of you in OncoAlert early 2027. So what to remember at the start of this new year? Are computational methods by default better than manual assessment? That's a question to you. Can we define what is a good AI-assay? Is there a golden standard, yes or no? And can we identify luminal breast cancer patients that are low genomic risk but have a high risk of recurrence? Yes or no? Special thanks to all of the people that have contributed to all these studies. And importantly, what I would like to stress is that these 3 studies that I presented to you, they took on average 5 years, 5 to 7 years to be more precise. So quality research takes time, and our funding agencies need to take this into account. Thank you very much once again for your kind attention. Thank you, Jill, also for your help in recording this, and look forward for the discussion. Thank you very much.